And good morning to everyone. This is Dr. Ara Deuk-Machen, CEO and founder of Deuk Spine Institute and the Surgery Center of Viera. We are located here in Melbourne, Florida, in the United States. Just an hour's drive from Mickey Mouse over at Disney and the Hulk and fellow Avengers over at Universal. So we're located here in Central Florida in a place called the Space Coast, which is where NASA used to launch the space shuttle and where SpaceX is now launching its vehicle. So we get to watch rocket launches day and night whenever they occur. And we have our facility here. We have a surgery center and medical office complex with diagnostic imaging. How are you, Luis?
Good. How about you, sir?
We've been in operation for 13 years, and we perform state-of-the-art spine care, whether it's interventional pain management, which are all the needle procedures, or it's surgery, whether it's minimally invasive, endoscopic, maximally invasive with fusions. We do it all here. We do it all outpatient, and we do everything state-of-the-art with literally the best outcomes in the world. So today we're going to be doing a 2-level cervical Deuk laser disc repair in a patient with herniated discs in the neck. This patient has 2 cervical disc herniations, and she presents with neck pain and right arm pain. So her neck pain radiates into the right upper extremity, down her shoulder, into her arm. She's had conservative treatment. She's from out of town. She and her husband drove from Miami to have the procedure done here because there's nobody else in the United States that does endoscopic anterior cervical surgery except for Dr. Joe in Pittsburgh, and he does a very different technique than I do. So we're going to get started, and we're going in on the left side of the neck. So if you think about, can you guys see Zach okay?
Yes, we can.
All right, so I'll just orient the viewers to what's going on. Our patient is here, laying on this table, and she's laying on her back, looking up at the ceiling, right up at the camera. This is her chin and her face. She has a tube. Can we turn the suction off for a second? We don't really need it right now. She has a... This one I can control. You can leave it on. She has an endotracheal tube in, and she's under general endotracheal anesthesia. In other words, she's completely out. We have our anesthesiologist, Dr. Santiago, here, who's taking amazingly good care of her. And she's asleep on a ventilator, completely out and completely relaxed. And I have Dr. Patel, my partner, here to assist me in the surgery. So basically, the middle of the neck is here. We're going in always in the neck. I go on the opposite side of the worst arm pain. So her worst arm pain is on the right side over here. I'm going to go in on the left side. I want this neck fully relaxed, so our patient is actually asleep with muscle relaxation as well, so that when I push on her Adam's apple or her pharyngeal area, she does not gag. So it's very important that I can actually feel the spine with my fingertips. I can feel the carotid artery and the jugular vein as well. And I'm going to use something called a fluoroscope, which is a machine that emits X-rays so that I can actually see the spine. And we're aiming for 2 discs today. The herniations we're fixing today are C4-5 and C5-6. We did a timeout just a few minutes ago to verify the levels. Now this technique has been peer-reviewed and published in the National Library of Medicine. I want to verify that the carotid artery is indeed lateral, which I can feel it, and the trachea and esophagus go medial. We're going to use a fluoroscopy unit shot, and I'm going to try to localize to the right level. So 2, 3, 4, 5, 6. Everybody agree 5, 6? All right. So I want to go a little bit higher because I kind of want to split the difference. I'm doing 4, 5, and 5, 6 today. So I want to start really between the two so that I can pull down a little bit and end up in 5-6 shot. And I can go up a little bit and end up in 4-5. 2, 3, 4, 5. So again, I want to be a little bit more north than I currently am. Everything okay? All right, good. Shot. Right there. 2, 3. So now we're at 4-5. So again, and this really does, unfortunately, the hardest part is what it does to your fingers as a surgeon. It really kind of hurts to put the pressure you need to. Shot. All right, so 2, 3, 4, 5, and then shot. So I slid it from 4-5 to 5-6. You all see that? A sneaky little slider that I am. All right. So again, shot. 4-5. Let's go AP. Make sure my needle's in the midline. I thank God that this patient has a thin neck. It makes the surgery a whole lot safer and easier. So, right? I've had some thick necks I've had to deal with over the years, and boy, they're challenging. All right, so we're a little bit off to her right side, so I'm going to pull it back just a little bit, shot. But I think we're pretty close to the midline. All right, go lateral. I'm happy with my AP view. Of course, my needle is really not supported, so it's tilted a little bit to her right, which I'm fine with. Look how I've displaced the endotracheal tube. Shot. All right, we're going to get started then. Shot. This is truly one of the hardest parts of the surgery right here. Shot. I'm in the disc. I can feel it. I'm going to let go. Shot. All right, let's go AP, Coker. So, for those of you wondering, what are you doing? We're doing endoscopic surgery. Why? Because it's less invasive. And if I do this on this patient, I don't have to put metal in. I don't have to put an artificial disc. We don't have to fuse. It's actually better than all those surgeries. All right, so I feel pretty good. We're off to the right side at the foramen, which is where I want to be. Her right arm symptoms are the worst, and the herniations are to the right side. So I feel good about this. Let's go ahead and do a discogram at this point. Yes, stay where you are, and then we're going to go lateral. But let me just do the discogram first. Watch your hands, Dr. Patel. I don't want you to get poked. So, how long have I been doing these endoscopic surgeries? 13 years. 13 years? No, sorry, 11 years. I've been in practice. How many years have I been in practice? 2004? Yeah, 15. So, yeah, 13 years. Sorry. Anyway. And I've done about 900. Let me have a Coker. Do not take a shot yet. "13 years, 900 laser surgeries." You can actually see the dye there compared to the image before. And I'm going to give a little bit more. And the dye is leaking out through a tear in the disc. That's the herniation. Shot? You can see it there. So, huh? Yeah, but let me just do one more real quick one, because I want to show our audience, hopefully, where the dye is coming out. Shot? All right, so that piece of metal, the tip of the metal thing that I just put there, look just above it. There's a little dot, like right there. Shot? Oh, I hate this. Shot? Right there, at the tip. There's dye, black dye coming out. That is dye around the nerve root. And the reason it's there is because it's leaked out of the back of the disc where the tear is, the annular tear that we're going to fix today. And it has gone out of the tear and around the nerve root. And that's the nerve that it's irritating. Shot? So you can see it on the lateral. A little bit overexposed. Can we underexpose it a little bit? Maybe bring in the plates. You know what I'm talking about, right? Collimator. The collimator plates. So I'm going to add a little more dye, and let me know when you're ready to take a shot. Go ahead. There we go. Beautiful. All right, so take a look at that needle that was in the disc space, and just past the needle, keep going backwards, there's a black line. That black line is the tear in the disc. That is what Deuk Spine Institute and I have discovered years ago is the cause of people's neck pain and back pain. We're the first to describe it, and by cleaning up that tear with the laser, we call it an annular tear debridement. By doing that, we're going to get rid of this patient's neck pain. And of course, when the tear itself heals completely, the nuclear material and the inflammation it's causing in the back of the disc there within that tear is going to resolve, and the inflammation will resolve, and the patient's neck and arm pain will go away. I expect their arm and neck pain to go away today. But you can see the tear that's in the disc. So I'm going to go ahead, and I've completed my discogram, and once again you count down. That's 2, 3, it's 4, 5. 2, 3, 4, 5. So you have to count from somewhere where you know, and the bone that we know is the number 2 bone. And it has a different shape. It's up there at the top. It's called C2. So every spine surgeon I know knows this. This is basic information. And we have to orient ourselves to what level we're operating at, because when you look at the MRI in the clinic, we know we need to operate at C4-5 and C5-6. And now you get to the operating room and, oh my gosh, well, where's C4-5 and C5-6? How do we know we're at the right place? And that's why we use a special x-ray machine called a fluoroscope. And it helps me figure out where I am. Shot by using metal contrasted against the x-rays, I can figure out if I'm in the right place. So it helps me localize to the right levels, but it also helps me see where my tools are, so I don't go too deep or too shallow or too left or too right or too up or too down. Yeah, we'll put a little local, great idea. So you can see now that the guide wire that I'm going to use to navigate to where I want to be from the skin or the outside world here, where we have all of our tools and instruments to navigate to the annular tear, the guide wire is in place. And I'm going to just do a little skin injection, because I don't want her to start having some bleeding from her skin, which Luis is very astute, because before we did this, we did a rhizotomy, and I noticed by watching Dr. Patel do his rhizotomy that there was a good amount of bleeding going on, right? Which is, you never want bleeding, but right here you can already see there's a little bit of blood, probably about 2 milliliters, but that's 2 milliliters more than I normally have at this point. So I think our patient is taking some type of an herbal medication, probably, that's affecting their bleeding. Now we tell all of our patients to stop those medicines. Let's get another shot. That's it? All right, nice. But sometimes they're on some kind of a new medicine we don't know about. Like the things that cause people to bleed are typically that are non-prescribed medicines, are your over-the-counter non-steroidal anti-inflammatories like Motrin, ibuprofen, naproxen, Aleve, BC powder, Goody powder, etc. There's others like Mobic, but those are prescribed anti-inflammatories. And then aspirin, right, St. John's worts. And then you have the herbals like ginkgo biloba, turmeric, fish oil, garlic. So we tell everybody to stop those, but sometimes they're taking something, a supplement we don't know about, or they don't know, or they forget to mention, whatever. So you get a little bit more bleeding. So I have to assess, is this too much bleeding? Is it not safe to proceed? And right now I'm just doing that assessment. So before I make a skin incision, I want to be sure we should proceed. So one of the things that I want to make sure is that we don't have a hematoma developing. Hematoma is a blood clot. I don't feel one. So when you did the rhizotomy, I haven't cut it yet. I'm waiting. When you did the rhizotomy, I noticed there's a little bit of bleeding Is it a lot more than normal, or? All right. So, all right, well, we numbed up the skin. We put some epinephrine in there as well. And I feel comfortable moving forward. I think it's safe for the patient. So I'm going to make a small incision. And when we do the Deuk laser disc repair in the lumbar spine, we make a 7 millimeter incision, 7 millimeters. When we do it in the cervical spine or neck, we do 4. So I want to bring this down right on my guide wire. You don't want to go too deep because there are in fact blood vessels just under the skin. One of them in particular is known as the external jugular vein, or superficial veins, and they're not just under the skin, but they're pretty close, within millimeters. And you don't want to you want to try to avoid piercing that. Okay, so I'm going to advance the dilator through the skin. I just made an incision. And people say, is this percutaneous? The answer is no. Percutaneous surgeries and procedures are always done with a needle, just through a needle, only a needle. We no longer are using a needle. We have a guide wire, and we're doing an actual surgery. And I'm advancing this, and it's going very nicely. But you want to always check your lateral view, Sean, because you don't want to advance the guide wire. If you advance the guide wire, then you might as well just call your lawyer, because you're going to paralyze the patient. And that's what's happened, not with me, but with other surgeons that have tried this in other countries. I know that they've paralyzed patients with this procedure, and that's why they don't do this anymore. But in 13 years, I've never paralyzed anyone or injured a nerve or a spinal cord. That's why being a neurosurgeon is an advantage if you're going to be a surgeon that does spine surgery, because one of the worst complications a patient can have is a neurological injury. And we're not going to have a neurological injury because I'm very careful and I'm very well trained. And I've done a lot of these. What's the problem, guys? Huh? Hey, Zach.
Yes, sir.
So we've been having these outages from the relay, and I don't know if there's a way to talk to Sonny. We need to have Sonny come and figure out a better solution.
I'll talk with him about it. You
Yeah,
mean
he
the
needs-
fluoroscope relay?
Yeah, the little box.
It's the power supply or the box.
It's either the power supply or the box, the relay box. Yeah. We replaced the power supply cord. It may be the box. But we just need a more reliable piece of equipment. Shot? All right, so we want a dark screen there on fluoro for a minute. Not us, but you did, because the link that transmits the image from the machine to the to our network for distribution out to you went down temporarily, but it's been an ongoing issue. So right now I'm passing the carotid artery and the jugular vein, and I'm just taking my time. Shot. And I'm making sure that needle doesn't advance. I don't want that guide wire. I called it a needle, but it's a guide wire. I don't want it going anywhere. Shot. You can see it's pretty well seated back there at the top of the disc. And my dilator is going to hit the annulus, the front of the annulus, in the front of the disc anytime. So let me back up and talk in general terms. What we're doing here today, folks, is a revolutionary spine surgery that has been peer-reviewed, published. It's all FDA approved, so don't get your panties in a bunch. But basically, I've been doing this surgery now for 13 years at Deuk Spine. We've done over 900, just about 900 surgeries, and we haven't had a single complication. Now, what we're treating is a herniated disc, 2 of them to be exact, and these herniated discs are causing neck pain and arm pain. This is a problem that literally millions of people suffer with around the world all the time. And this surgery you're watching right now is literally the newest, most advanced, state-of-the-art treatment in the world for it. And it's outpatient. When I get done here in about 45 minutes to an hour, This patient will be extubated, they're going to go to the recovery room, and they're going to literally go home an hour afterwards. No hospitalization, fully outpatient, and not a single complication in 13 years of doing it. And that's all been published in the medical literature. So why do this? Why do this particular surgery for herniated disc? What are the alternatives? The alternative is to make a slit, a bigger incision, take the whole disc out, put a spacer and a metal plate. That's called an ACDF, or anterior cervical discectomy infusion. This endoscopic Deuk laser disc repair surgery you're watching now replaces that surgery, the ACDF. The other option is to make the same big slit, take the whole disc out again, but this time instead of fusing with a metal plate and a plastic spacer, you put a metal and plastic artificial disc that still moves. Again, inferior technology by leagues compared to the endoscopic surgery. So anytime you have to put metal and plastic in a patient that shouldn't be there is always, you know, in my opinion, if there's a less invasive or a less traumatic surgery that doesn't involve implanting something foreign in the patient, it's always better. This Deuk laser disc repair is all natural. So I've got my basically my dilator right at the anterior annulus. So right now I want to get another x-ray, but I want to go AP, and I want to see where the tip of my dilator is, because that's going to tell me where my entry point is on the anterior annulus. People ask me, well, when you go through the anterior annulus, doesn't that damage the annulus? Yes, probably it does. But that's not important, because the anterior annulus is not a source of pain or radiculopathy or nerve compression or spinal cord compression. All right, so the dilator tip is right in the midline of the spine, which is exactly what we want. And then once we penetrate the annulus, we go off to the right side, which is exactly what we want. So let's go back to a lateral view. What I'm going to do now is I'm going to advance this dilator through the front of the disc. And again, I want you to understand that the tip of this dilator is tapered, meaning that it comes down to a fine point. And the purpose of that is to actually spread the tissues open, not damaging them, not cutting them, but spreading them. And there are natural fibers in the front of the disc that allow me to spread the front of the disc, or anterior annulus. Of course, there'll be some very minimal damage, but that's collateral damage for this procedure, which is absolutely minimal. In an ACDF or a artificial disc, we're going to be cutting those fibers out. Shot? I felt myself passing. Is that it? So I'm feeling it starting to pass through the front of the annulus. I like to roll and push, but I want to take my time and do it right. I'm not going to try to speed things up. I'm just trying to gradually advance the shot. And if you can't do it with your fingers, which is fine, a lot of times you can because there's a tear in the annulus. Shot. In this patient's case, there's a minimal tear in the annulus. So now that I'm inside the disc, shot, okay, I can now take the guide wire out. Here you go. And what I'm going to do now, shot, is I'm going to look at my alignment, and I'm going to target the back right side first. And I'm going to use my mallet, which is a hammer, to gradually advance, shot, through the disc. Remember, we're spreading the disc open with the tip of that dilator. Shot. Is that it? All right, perfect. So now we're in the back of the disc, right where the annular tear is. And I'm going to, at the right foramen, which is where her arm symptoms are primarily. Now, I'm going to bring in the actual retractor. What's a retractor? Well, surgeons use retractors to spread open tissue so they can get down and fix something inside the body. So a lot of the problems humans have that need surgery are deep inside the body. So you got to get through all those, what we call superficial layers of tissue, which are the ones out by the skin, and we got to move them over so we can see down there. So the whole surgery is going to be done through this tube. Can you guys see this, Zach?
Yes, we can.
So when we're doing lumbar surgery on people's lower backs to fix herniated discs in the lower back, we use a much wider tube, or tubular retractor. And I call that the McDonald's shake straw, because it's much bigger so you could suck that thick shake up. But this here is more like a coffee straw, okay? And you can see it's absolutely tiny. The distance from one side to the other is 4 millimeters. So when you're done with your surgery, you literally have a 4 millimeter incision. I mean, it doesn't even take a suture to close it. We use a steri-strip. And that's why it's so minimally invasive. This is the most minimally invasive spine surgery done in the world, the Deuk laser disc repair. So I'm going to run that tubular retractor down right over the dilator. And again, I'm using a rotating back and forth movement. I'm going to move a little bit faster because you're all experts now. And of course, I'm going to continue to use my x-ray machine to monitor my progress as I advance. But I can actually feel this thing, and I can feel when I'm getting close to the disc. Like right now, I feel I'm on the disc shot. Yep, we're right on the anterior annulus. And I want to make sure that my dilator, once again, doesn't advance, because you don't want that in the spinal cord. And the spinal cord is literally 3 millimeters from the tip right now. All right. So I feel pretty good about this. We're getting caught up on the skin. I've made my incision exactly 4 millimeters. The outer diameter of this tube is 4 millimeters, so the skin is actually what's giving me my resistance, but I'm good now. So once you get the tip of this tubular retractor down on the anterior annulus, you're going to use another tool to advance the tubular retractor. Okay? And again, I'm paying attention to my angle here with respect to the patient's spine. I want it at about 30 degrees off mid-axis. And I'm going to advance the outer as I look at the dilator and make sure the dilator doesn't go forward. And you don't want it to go backwards too much either. Any questions while we're doing this?
We do have one. We have a viewer asking, Dr. Deuk, how are the long-term results of this surgery, say 5 to 10 years later? Are their symptoms gone / minimal at this time?
Yeah, so one of our viewers watching this, and by the way, I don't think I mentioned, this is live spine surgery you're watching. Now, yes, we broadcast on multiple platforms. One is YouTube, the other is Facebook, and the other is Periscope. And you're able to come back later on another day, and you're able to watch this surgery recorded. But if you're literally watching right now at 10 o'clock Eastern Standard Time, which I don't know what time zone you are in, because we have people watching these surgeries all around the world. We have people in South Africa, people in Russia and China, even Korea, all over the world watching. So I don't know where you are and what time it is, but right now where we're doing the surgery, it's 10 o'clock Eastern Standard Time. And the date is April 25th? April 25th, 2019. So if you're sitting here watching this on the internet, April 25th, 2019, you're watching a live surgery. The reason we broadcast live is so I can answer questions and I can teach as I go along. Plus, we want you to see a live surgery because it's interesting and we can't hide anything. So if I screw up or if there's a problem, you're going to be part of it. You're going to see it in action as it unfolds and how we manage it. It's part of transparency. I'm a big believer in truth and honesty in everything I do, particularly in how I practice medicine and how I interact with patients and viewers and the public. So I want people to see what we do. Now I'm also confident that we're not going to have a problem because I've done so many of these and I honestly have never had a problem. I've been able to do it carefully from the beginning without any issues. But we want you to enjoy a live surgery. It's always more interesting watching a live surgery. So to answer your question, we've already looked at long-term outcome data for these patients with Deuk laser disc repair. And we had a study that we just did that's going to get published soon where we looked at minimum of 5 years follow-up and what the results were with our patients. And with a minimum of 5-year follow-up, those patients had 93% relief of their pain in their spine, in their neck or back, as well as their arm or leg. So it turned out, though, that if we made the cutoff 5 years minimum follow-up, the actual number of years we had was 6 years on average for the group, for all the patients that met what's called the entry criteria, okay? What we call the inclusion criteria. So one of the inclusion criteria is we had to have 5 years minimum follow-up for all the patients included in the study, and it turned out we ended up with 6 years on average follow-up, and with a 93% ongoing relief of pain. So that's phenomenal. I don't know any other surgery in the world that offers that high of a success rate that long out. And by the way, there's virtually no studies published right now. We found this out as part of our as we made the manuscript that we were submitting for publication, was that there are no studies of 5-year outcomes for endoscopic spine surgery. We're literally the first ones. So we're waiting for that to be published soon. All right, I'm going to go ahead and move forward. And what we're seeing is, I don't know if Zach switched you over yet.
We can see it.
Huh?
We're switched over.
All right, so we're looking down the endoscope, and that's the laser fiber. I'm going to do my best to improve the focus and the view, but the fact of the matter is that the cervical scope is not the same as the lumbar. The lumbar scope, which is what we use on the lower back for those surgeries, has a what's called a rod lens configuration to the scope, which means you're getting a real image. The cervical scope, on the other hand, has a fiber optic transmission pattern through the shaft. So rather than rod lens, which gives you a clear picture, it has a fiber optic view. So you're going to have a more grainy appearance to the image, which is fine. I'm used to it. But you, the viewer, may have a little harder time. So we need to go down on the light. We're a little overexposed. Yep, one more. That should be good right there. I may need you to take it down one more. Now we're at 20, right? At 20. I just need to find the pedal. Let me just think. Yeah, let's go down one more click on the brightness. We're still overexposed. I think that's good. So what I'm looking at, folks, right now is the herniation. We're literally, if you look at where the tube tip is, and this is the tip of the tube, it's quite literally where the herniation is. And there's a piece of herniation right there coming back at us. In our paper that we published in 2013 on this surgery, we coined the term reverse herniation. And what it means is when you start to use a laser to zap away the scar tissue at the base of the herniation in the annulus where it's stuck down, you're actually going to get pieces of herniation coming back right at you like that right there. You see that? It shot out. So anyway, that was what we call a reverse herniation. We were the first to coin the term and the concept. Also the first to perform an annular debridement and publish it. So the laser fiber is at 12 o'clock. It's a little glass tube that you guys are seeing. I can see inflammation down there. You guys see the inflammation? Here's another herniation. You see the inflammation right there? You see that pink right there? Pay attention. That's one of the most important things I'll ever show you. That's why people have neck pain and back pain from a herniated disc. So really, there's nobody else in the world that will show this to you. I'm the one who discovered it. Granulation tissue within the annulus. Now there is one person who helped me look for this, and he's a neuroanatomist, not a surgeon, not a doctor, but he pointed me in the direction of looking for inflammation. And what that is, folks, is granulation tissue. Granulation tissue is pink, and it's full of blood vessels that are highly leaky and full of little nerve endings that are extremely painful. And that is why this patient's having their pain. So I got to zap it away. You can see there's actually a bone spur related to it because chronic inflammation creates what's called dystrophic calcification. And that's what a bone spur really is. How do I know so much? I'll tell you why. Because I really paid attention in medical school. I actually graduated with the highest GPA in my medical school at USC. I was basically the valedictorian of the medical school of my class. And pathology was probably my strongest subject besides biochemistry, which was my major. As a matter of fact, since this is a time capsule, and I'm not trying to impress you, but I'm trying to record facts. In the pathology final at USC in Los Angeles, I scored a perfect score on the final exam at the end of the year. It had never been done in the history of the medical school, 125 years at the time. And both instructors who wrote the textbook on pathology felt compelled to mention that to the entire school at graduation, which I felt very honored, of course. But obviously I have a very strong understanding of pathology. Pathology really is the essence of human disease and human illness. It's a deviation of normal anatomy and normal physiology. So medicine really is a science devoted to understanding pathology and correcting it in human beings. So pathology, in my opinion, besides anatomy, is probably the most important course. For those of you who are aspiring to do great things in medicine, you have to be masters of pathology and anatomy. Just my opinion. All right, so right now we've got this camera and scope inside the disc, and what I'm using the laser to remove, this is all the annular tear. It's all scarred up and gunked up, and there's herniated disc inside it right here. And look at all that. Every time I blast it, it kind of turns like a whitish gold color. That's all calcified scar, basically chronic calcified scar. It's bad stuff. It's indication of disease, an indication of inflammation, chronic inflammation. And inflammation causes pain. So think about, for example, acne, right? Zits. Zits are inflammation of basically follicles, little follicles within your skin. And is everything okay? And stand by. I'm going to grab that herniation out with a grabber. So think about like the most painful zit you ever had, and you touched it with your finger and it hurt like hell, right? Now, imagine that times 10 in the back of your disc. Like 10 zits. Now, zits are inflammation of hair follicles or sweat gland follicles in your skin, and they're due to bacteria growing in that follicle, right? Bacteria growing in there. This patient's inflammation is not due to bacteria, but it's still inflammation, the same as the bacteria causes in acne. So it's the same source of pain, which is bacteria themselves don't cause pain. They're tiny microscopic organisms. What they cause is your body's response to them, which is an inflammatory response. And the inflammatory response is inflammation, which is redness, swelling, increased temperature, and tenderness or pain. So this patient has an inflammatory response right here where I'm working due to this blue stuff right here. That's the herniated disc. Okay? So it's squeezing out of the disc space and going around the nerves and the spinal cord and creating inflammation in the outer annulus, and that inflammatory response is actually causing this patient's pain in their neck and down their arm. So this is something that basically I have discovered as being the source of neck and back pain. This is the reason I'm able to cure people's neck and back pain, is because I understand the source of it. Whereas other doctors and other surgeons don't understand it at all. Now, pain management doctors have a decent understanding because they understand it's inflammation. And that's why they do epidural steroids and facet joint steroids. They do a lot of steroid shots because they understand what's happening as a joint is painful because of inflammation. But surgeons, for the most part, don't think about spine disease as being inflammatory. They think about it as being compressive or structural. So most surgeons are making a huge mistake in overlooking the inflammatory component of people's disease. because they don't pay attention to inflammation. Only neurologists do in the neurosciences. Neurologists treat inflammation, and neurosurgeons ignore inflammation. So I'm different from most neurosurgeons because I don't ignore inflammation. I realize the value and importance of inflammation. I learned that from Dr. Patel, my partner, and my sister, Dr. Schrumpf, a chiropractor. Those people taught me the importance of inflammation and in treating the human disease and condition. So this is the right foramen at C45. You can kind of see some of the PLL and maybe even some of the dura. There's a big tear here, and I'm just debriding the tear right now. And I'm controlling this laser so it doesn't go too far. That's all posterior longitudinal ligament right there. And this is the foramen. So I'm trying to get out as much of this material from the foramen as I can, because that's what's irritating her nerve. All right, but I'm not going to go crazy. I'm not going to hurt her for the sake of getting all of it out. What I found is that I have a pretty good idea of what's enough, right? There's an old saying for physicians, first do no harm. What that means is don't do too much. Don't go overboard. Don't do things that hurt the patient, right? Don't intervene in a way that make the patient's condition worse. So I believe that's an important principle to live by and to practice by. So I don't go crazy and overboard to hurting a patient. I've never in my life had a patient wake up worse from surgery than they went in, ever. Almost always my patients, they're doing fantastic as soon as they wake up, which is what I like, what they like. That's my goal. And so to do that, you have to make the right choices in the operating room, right? So intraoperative complications occur as a result of surgeons' involvement, and I won't say mistakes because it's not always a mistake. You can have a complication even though you've not made any mistakes. So I'm, to be honest with you, have, I'll call it the luxury of doing what's called elective surgery. It doesn't mean that it's not necessary, it just means that it's not an emergency. And my colleagues that do emergency surgery are faced with situations where a lot of variables are out of their control, right? So you have a patient who's dying and you have to act quickly. You can't sit around and wait for them to get medical clearance from their primary care doctor. Whoa, look at that. Or see the cardiologist. That's a herniation coming out. I just floated out. So they're actually dealing with more complex issues. So people wonder, oh, why is this surgery more expensive at this hospital or location than it is at that? Probably because that hospital is seeing a different type of patient. And it's important that we understand that. They may be seeing sicker patients. That's a tear, by the way, right there. And if the hospital is treating sicker patients that have more complex issues, medical issues, then of course the costs are going to be higher. So we have to be understanding of that as a society. What truly needs to happen is the insurance companies need to do their damn job of paying the bill. I was just reading in the news that United Healthcare posted the first quarter profit of 2019, and it was almost $4 billion in profit. $4 billion. Now I want you to think about that. $4 billion in profit. So I want you to understand a few things. Number one, these insurance companies are the biggest money launderers on earth. They literally have overseas companies that they pay huge amounts of money and basically transfer all that revenue overseas to companies that are not regulated by our government. Therefore, we don't pay taxes. Therefore, as well, they don't have to report it to the, what is the governing body of the stock market for publicly traded companies, the SEC. So they avoid all the SEC reporting requirements because they basically funnel billions and billions of dollars out into what are called subsidiary companies that are service subsidiaries of United Healthcare Group. And so they don't have to claim that as profit because that may be a cleaning company, the janitor company, that they pay $1 billion a year to clean their 10,000 square foot office. And so of course all that's gravy, and it's unregulated by the government because it's not United Healthcare. It's not a health insurance company. It's a janitor's company that's just being overpaid because it's owned by special people. Well, these special companies that are service companies of United Healthcare, Blue Cross Blue Shield, Cigna, they all play the game. They are unregulated, and they don't have to report their profits because they're probably private companies. So my point to you is, pay attention, America. Don't let the insurance companies steal your quality of life and your health care. You're paying premiums, and they're basically taking all that money and putting it into accounts overseas and only reporting a small amount here in the States. So that small amount they report, it still turns out to be $4 billion in profit. Okay? So you know where that money comes from? I'll tell you where it comes from. You. And it comes from denying medications that you need. It comes from denying payments to hospitals, denying payments to doctors, denying payments to physiotherapists, and denying payments for surgeries like this surgery right here, which is a life-saving surgery. A quality of life-saving surgery. Okay? They just deny anything they want. And by doing that, they make more profit. Okay? So as long as you want to keep letting them do that, by all means, you're going to keep paying more and more of the medical bill. And high-quality medical care is going to disappear because doctors aren't going to work for free. I'm sorry. Yeah, I know that may sound as a shock, but we don't work for free. Dr. Santiago, you going to work for free?
Absolutely not.
Dr. Patel, you going to work for free? Anybody in this OR want to work for free for the next week? No? Why not? Just free. The insurance company doesn't want to pay. They would rather buy another yacht or something. Sorry? Yeah, you can switch the irrigation bags. Thanks for asking. Yeah, you're fine. Go ahead and switch it. Yeah, the point I'm trying to make is, folks, this surgery's been around for 13 years, and I'm talking about United Healthcare right now. They won't pay for it. Why? It's better for patients. It's cheaper. It's zero complications, but they want patients to have a fusion. Anybody know why? The answer is simple, because most patients won't. So it saves them money in the long run. That's where we are right now in healthcare. Insurance companies are making the decisions about your health, whether or not you get treatment, and what treatment. Whether it's a new medicine, a better medicine, they'll deny it because it's more expensive, or it's a new treatment, or it's a new test, they'll deny. They don't just deny this procedure, they'll deny everything, and they are, by the way. Huh? Yeah, medicines and drugs. So just to give you, yeah, blood pressure medicine, everything. Just to give you an idea, how do I know all this? Well, because I grew up in a medical family. My father was a doctor. He was not just a doctor, he was a captain in the U.S. Army, and he was a doctor in the U.S. Army. So I went to his office as a young kid 40 years ago, even 42 years ago, and there were none of these issues with the insurance companies. They would never dream of denying a patient access to health care. Everything the doctor wanted to do, they approved. Yeah, people would pay cash, and then they would get a receipt. They would submit it to their insurance company. The insurance company would pay the patient. And that system worked beautifully. Beautifully. And there actually were no copays either, or deductibles. Just the insurance would negotiate on a case-by-case with doctors or come under contract. And it worked beautiful for everybody. And that's the golden days of medicine, America. That's when the United States was literally ranked #1 in the world in healthcare. And all of that has been absolutely bastardized over the last 42 years, where the denials are now high. Every day there's millions of denials that go on by the insurance companies. Denials. Denial. And of course, who pays the price? The patient. And hospitals are closing as well. Doctors' offices are closing. Doctors are going to work for the hospitals because they can't stay in business anymore. So you wonder why all this is happening? I'm telling you why it's happening. I've already solved the problem. I know why it's happening. The question is, are you going to act on it and do something about it? I can't do anything about it. I'm just a doctor. And I'm not running for president. I already see how that works. I've been in politics too. I know how politics work. You can have somebody who has all the solutions and answers and great ideas to help the people, and they just get shut down by all these special interests that have no interest in representing their constituents. So, It's broken. Yeah, it's a broken system. Everyone wants to say, if I say I have a great idea, I can fix it, they'll say, no, we don't want that great idea. It's incredible. People are in politics for themselves rather than for the people they represent. What's that? We need to. We need to get together and act. The problem is that people are too trusting of their government, and the government is being manipulated by big business lobbyists. And they're not acting in the best interest of the American people. And this has been going on for 50 years, 70 years, whatever. All right, we are just about done. I told you I wouldn't get involved in politics or talk about politics, but the truth is I will talk about politics when it relates to medicine. Okay? And this relates to medicine. I'm not going to talk about political candidates or anything else like that because I don't think it's appropriate for me to talk about it. I'm not an expert. But I will talk about issues that are related to healthcare and access to healthcare, patients' access to healthcare. And I will always tell you the truth. And I won't say if I don't know it, I won't tell you. I won't talk about it, or I'll just say I don't know. I know that I don't know everything. I'm not even close. But I do know a lot, and I know a lot because I run some medical businesses as a CEO, and I've been involved as the president of the medical society, as the chief of staff at the hospital, as the president, as the chief of surgery department at the hospital. So I know. I've been sitting on the board meetings at the hospitals. I am friends with leaders in medicine. We talk about these issues. They're common issues that everybody's experiencing. So, pretty cool. Look at that PLL, right? A little very fine fibers of the PLL right here. And then below that, look at that down there. All right, so this woman has basically annular tears, herniated disc, and I'm happy. I think we've gotten it all. Again, we don't want to gild the lily and do too much and cause a problem for her. So I'm just going to keep coming back and checking, because sometimes when I shift to the other side, little pieces of herniation will sneak down there into the foramen, and I don't want to leave any of that down there. So I want to make sure we get it all. Sometimes I have to pull back a little bit on the retractor and reposition. Zach, you have any questions from our audience? Or are they just going to let me keep talking?
We do have one. We have a viewer who wants to know, how many of these procedures have you done in the neck specifically?
How many of these procedures have I done in the neck specifically? That's a great question. I don't know the answer. I would say of the 900 that we've done, Deuk laser disc repairs, probably a third, so say 300 in the neck. I would say a third to not quite a half. So I would say 300. And the average number of discs that I fix per surgery is about 2.5. So that means the most patients have more than one disc as the problem. Now we can do one disc, but then you're going to be back again. And who wants to come back for a second surgery? Dr. Patel? Nobody does. So I'm a big believer in fix what needs to be fixed while you're there. Yep, nice job. Watch the squirt, Carl says. That's a little inappropriate, isn't it? But thank you. It's like a leaky bladder. You see that? All right, so we finished one disc. We're going to move on to the next. This is the squirt Carl's talking about. Now, I'm teaching you all my secrets here. But the way we get to the next disc is going to be by removing the tubular retractor. And before we do that, I don't want to start all over again. There are reasons for that. So I'm putting the dilator back in, and we're going to then move from C4-5 down to C5-6. One of the nice things about this particular patient, she's young, and she doesn't have a lot of bone spurs in the front of the spine. Many patients I've treated have big bone spurs in the front, but she's got a tiny little osteophyte at the bottom of C5. And I've had people with large osteophytes. It makes it a little more challenging. I even had one patient that came all the way down here from South Carolina to have the laser surgery done on his neck. And I can't tell you his name or anything, but he was a pastor at a church. And we tried to get into that disc, and we couldn't because he had a giant bone spur just sitting right, shot right in front of that disc, okay? And so it was blocking my access to the disc. Okay, take that off. And we ended up having to do a fusion instead. So we took care of that and got it done. And we did it right here at the surgery center, outpatient shot. That's where I'm at. So 2, 3, 4, 5. You have a question for me, Zach?
We do. We have a viewer asking, if my MRI is 3 to 4 years ago, I've had physical therapy, steroid injections, no improvement, would you need a more current MRI for review?
Yeah, so we have a viewer who's saying, I'd like you to do a free MRI review on my MRI shot. Would you do that? Of course, we'd be happy to do it. And they're saying, but my MRI is 3 or 4 years old. Is that too old? The answer is yes, it's too old. I need an AP view. The MRI of 3 to 4 years of age is too old. Coker? I need something that's about a year old or less, preferably. I could accept something a little bit older, maybe a year and a half at most. But remember, this is your spine and you want it done right the first time, so please, more. All right. Shot. Dr. Patel, you know you will possibly never do this. There's too much surgical risk here. But, you know, maybe someday you could. I trained Dr. Patel how to do kyphoplasty, go lateral. And honestly, I think he's probably better than I am now at kyphoplasties. And he does all the kyphoplasties for our Deuk spine. See how the fiber is sticking out? I don't want it to break off. All right, take this. So I checked my AP position, and at first I was too far to the patient's right. So you want to correct that. Shot. And now I'm moving down the spine, staying on the ALL. And shot. Again, this is a technique that I developed at Deuk Spine. Nobody ever taught this to me. Shot. And this is literally the hardest part of the surgery. Shot. Can you extend her neck a little bit? Go AP. Take, give me it to me, please, Coker. Oh, no. It just slipped. All right. Just forget about extending it. I think she's pretty well extended anyway. Shot. Is that it? All right. So I'm a little bit... she's got a little scoliosis there or something. I'm going to go a little bit to her right. Just the tiniest amount. It's hard to feel. Shot. That's perfect. Lateral. So I want to be in the midline. The reason is there's two muscles that run along the sides. They're called the longus colli muscles. You want to try to avoid going through them because they're in the front of the spine for two reasons. Mallet. The first reason is the sympathetic trunk runs through them. Shot, which is if you injure it, you're going to get a Horner syndrome in their patient. Shot. So I'm starting to dig into the anterior annulus. Good. Shot. As I get in, I want to check my AP position and make sure I haven't moved. Because if you go to the side, you're going to kill the patient. And we're not going to do that. Because you got your vertebral artery over there, you got your carotid and your jugular. And long story short, this surgery, though I make it look easy, is actually extremely risky and complicated. All right, lateral. But it's kind of like watching Dr. Art Day or one of the top vascular surgeons, neurosurgeons in the world, operate on an aneurysm like a basilar apex aneurysm. They make it look easy, but it's actually one of the hardest surgeries in the world to do. So don't try this at home. Shot. We are trained professional. Shot. Don't do this in your garage. Shot. Don't try this at the local Starbucks. All right, so you can see that we've advanced the tip of the dilator to the back of the disc, right where the annular tear is. And we need to do a discogram. So to do that, I first have to pull back just a little bit. Right there, shot. Yeah, and I want a pipe cleaner. And no, I'm not talking about X-Lax. Tough crowd today. Shot. Huh? It went right through the tear. You see that? I mean, no resistance at all. My retinas are working pretty good. Shot. All right, look at that. Wow. Huh? So, just so you know what's going on here, the shadow you're seeing across the whole spine is just the water here, the irrigation in the bag, because it has Omnipaque in it. Let's try again. So that should be gone. It's gone. And then you can see the dye actually shot right through the tear, and it went into the epidural space. And it's now layering out around the spinal cord, just in front of it. But that's amazing, because that tear must be so big, and it must be so scarred that none of the dye even picked up by any of the disc material along the tear that we normally see. So, right? Wouldn't you agree? Yeah, we're going to get an AP, but I got to try to get some dye in this disc. Hold on. I got to pull back just a little more. Shot. I really want to have some of the disc illuminated. Shot or stained. Jeez. Have you ever seen a discogram like that? All right. Go ahead and get an AP. Take. So what we're commenting on is, like, there's a literally, I don't even know what the widest highway in the United States is. Yeah. So, I mean, the epidural stuff, Patel, it just dissipates that quick? Diffuses? There's a little bit, right? Yeah. But there's also on the right a little higher up, mostly left. So whatever the widest highway is, that's how big this tear is probably going to be. It's huge. So unfortunately, it's not staining much nucleus. It's just literally going out epidural. You agree? I mean, that's in the epidural space. It's not outside the spinal canal. It's within the spinal canal. All right, so we've done our discogram at the second disc. We're now treating, see, count from the top, 2, 3, 4, 5, 6. So we're treating C5, 6. We've already treated C4, 5 with the Deuk laser disc repair. We're doing 4, 5, 5, 6. So we're doing the right levels, the proper levels that we're supposed to be. Again, we're going to put the tubular retractor down. Now, of course, I've gotten some of this Omnipaque dye or whatever it is we use. Is it Omnipaque? Dye on my gloves. So now it's making them sticky. It's kind of like if you spilled a Coke and given it an hour or two to dry, it's super sticky. Huh? I can wash them off down here? All right. So what other questions do we have from the audience? We're getting ready to start. The water's good. It's lubricant. To start the next disc. Shot. Zach?
We have a viewer asking what the complication rate is for this surgery.
What is the complication rate for this surgery? For this surgery, Deuk laser disc repair, it's 0 at Deuk Spine Institute, where it was created, and I being the creator. Okay? It's 0. And that's been published, peer-reviewed and published. 0. Shot? It's the only spine surgery in the world with a 0% complication rate. And I'm going to keep it that way. I'm going to keep it at a 0. Hopefully the other surgeries will catch up. Shot? 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 Just for reference, our complication rate with fusions is less than 1%. So if you understand what fusions are and what their complication rates typically are, they're typically about 10%. My complication rate with spinal fusions, and I do complex spinal fusions, multi-level with reconstruction, is less than 1%. So that's as high as 50%, and it's as low as 5%, but there's nobody else that has a 1% or less complication rate that I know of in spinal surgery, spinal fusion surgery. What I'm getting at is, you know, we do our surgeries very cautiously, meticulously, and we're able to really pay attention to the patient's other medical issues and factor them in and account for them and basically circumvent any complications or minimize the risk of complications by really optimizing the patient's medical and surgical status before surgery and after. It takes a lot of work and a lot of people, but that's why our complication rate is so low. Plus, I do spinal fusions that are elective, meaning it's not a trauma like a motor vehicle accident, person's paralyzed, they're coming in. I literally do mine, I do my spine surgeries on patients what are called elective surgeries. So it's very controlled from an anesthesia standpoint, controlled from a anatomical standpoint. There's no blood clots or infection or anything like that. So again, it goes back to the comment I made earlier. I'm very fortunate to be able to have a practice where literally people travel from around the world to have these surgeries done, and we make sure that they're medically optimized before we do surgery. So the risk of complications is reduced because of that. Plus, we have very good technique, and we have really the best post-operative and preoperative strategies to minimize risk to the patient, which is why our rates are so low. But it's definitely something worth discussing because I know there are places you can go for spine surgery and have a 50% chance of a complication, serious complication. As a matter of fact, there's a facility right here where we are that does spine surgery and actually kills patients, which is beyond me how you can kill a patient during a routine elective spine surgery. But I won't mention any names, but they've been around longer than Deuk Spine. But this is not uncommon, by the way. I mean, the risk of spine surgery is quite significant, right? I mean, after all, we're operating on the spine and near the spinal cord and the nerve roots. So, yeah, you've got to do it just right every time. All right. Well, there's a herniation right there. It's white. It's scarred. It's sitting right, inside of the disc. So it's a contained herniation. You have a question there, Zach? I hear you.
We do. We have a viewer asking if we'd be able to treat Chiari malformation.
All right, am I able to treat a Chiari malformation? The answer is yes, I can treat a Chiari malformation because I'm a neurosurgeon. And those are the type of surgeons that treat Chiari malformations. My question would be, does your Chiari malformation need treating? So the reason I say that is there's a lot of people with Chiari malformations that don't have any symptoms from them. And are you one of those people? And your answer to me may be, well, I do have symptoms. And I agree, you probably have symptoms, but are they from the Chiari malformation? That's the key. And that's where a lot of doctors make the mistake of treating a Chiari malformation when it doesn't need to be treated because it's not causing symptoms. So my question to you is, what symptoms are you having that you are attributing to a Chiari malformation? Because you may be wrong in your attribution. And I will not operate on a Chiari malformation unless I truly believe it's the source of people's persistent and ongoing symptoms. There's a reverse herniation coming out. Step into the light. What is taking so long? All right. So to answer your question, yes, I can treat a Chiari malformation. I assume it's a Chiari type 1 malformation. I could be wrong in my assumption. I don't treat Chiari type 2 malformations. Those are best handled by a pediatric neurosurgeon, in my opinion, and a team at an advanced hospital. Any other questions from our audience?
Not yet.
See how nice the laser removes the herniation? I mean, it just zaps it away. That's all herniation, by the way. And it just didn't stain. And there's fibers of the PLL just down there. You see them? Dr. Patel, you're getting the education of a lifetime. So, it's a lot like playing a video game. Now, I'll tell you something. I was a really good video game player. I mean, really good. And people don't know this, but I'm going to share this story with you. I'm 49 now, and one of the first-person shooter video games that ever came out was a video game called Doom. There was some before it, and I played them. And I was really big. This was back in my college days at UC San Diego. Really, really, really big into online gaming. And I played Doom online a lot, and I was truly one of the best players probably in the world playing. So Doom made a movie. Maybe some of you have seen it, right? And there's a character. My name was Deuk when I played. Deuk, of course, or Duke Majan and Duke Spine, whatever. Anyway, there's a character in the movie named Deuk, and that character is after me, and the other characters are people I played with online. In the movie, Deuk is African American, which is fine, but I'm not. I just thought it was interesting. So many years later, after Doom became popular, they created a movie. Isn't Dwayne Johnson? Dwayne Johnson is like the lead character. Anyway, there's other characters in there that I used to play with when I played Doom. And so I have a character in a movie named after me, after my video presence, or whatever you call it, my avatar. This was back in the very beginning of online playing, by the way. Now online playing is everything, but back then it was always you play in the console. But then they introduced basically web-based play. So that's a good movie, by the way, if you haven't seen it. It's a horror movie. It's a little dark, but so is the game.
We have another question.
Sure.
We have a viewer who says, I have bulging, possibly herniated disc in the cervical area, herniated disc in the thoracic area, and bulging discs and stenosis in the lumbar area.
Yeah.
Could all of these be treated in one surgical visit?
So somebody is saying I've got herniated disc in the cervical, thoracic, and lumbar. Can you treat all these in one visit? The answer is yes. It has to be a very long visit. You might as well check into an apartment or a condo. No, seriously, we can't do them all in the same surgery, but we can do them all in the same visit. It's not a problem. Generally, we would want to space the surgeries out at least for a few days. If I had my preference, it would be at least a week to recover from one surgery to the other. But we recognize the fact that people are busy and they have lives and they want to get in and out and get things done. So yes, we could accommodate you, but it would not all be done in one day with one procedure. It's not safe to do that. So we don't do things that aren't safe, even if people ask us to. Even if they, want us to or threaten to leave, we just show them the door. I'm not interested in jeopardizing anyone's safety for an elective surgery, period. So to answer your question, yes, you can do it in one stay, but you're going to need to be here for probably at least 2 weeks if you have that many herniations that need treatment. My advice to you is to start out with a free MRI review, which we'll do for you. No charge, no obligation. Send in your MRI of your body parts, like your neck, your cervical, your back. Let me review them. And let's do a video conference if you want, where we get on the phone and we talk about what's going on, and I get to examine you on the phone. Okay? And let's come up with a treatment plan before we even get out here. Something that's reasonable and that will work. And by the way, the MRI review is 100% free. Are you running out of irrigation? Yeah, I can tell because I'm getting some blurriness here, some air bubbles. So the MRI review is completely free. The face-to-face conference over the internet we use, what the heck is that app we use? I can't remember, but we use some app. Zach, what is it? Skype. So we can do a Skype, 10, 15-minute call, and that's, again, free, no obligation. Why do we do all this? Because we want to help people. Because we can. Okay? Because we can. Because I'm the boss, and I get to decide what we do. And who pays for it? Me. So I'm going to pay for your care to be initiated, at least to get you in the right direction. If you don't come here, it's fine. We're not requiring you come here. We just want to help you get on your way to being recovered and getting better. That's what Deuk Spine is all about. Our whole culture, our whole philosophy is about helping people overcome their illness and get out of pain and suffering. So I can provide as much free advice and free anything that I can, but I'm limited because we don't get government subsidies, we don't get donations. Nobody's, whatever his name is that owns Facebook, Zuckerberg, has never sent us a check. Bezos has never sent us a check. Nobody's ever sent us money to help people. It all comes from people's pockets, our patients' pockets, and from insurance companies. We have to sue sometimes to get them to do the right thing and pay. But fact is, I do as much free care as we can afford to do, but I do have bills to pay, and it's my responsibility to make sure that we stay in business so we can keep helping people. So, long story short, we still offer free MRI reviews and free face-to-face conference. And if I were you and you're suffering and you want to know, take advantage of it. Do it. At least get my opinion. I'll set you in the right way, and from there you decide what you want to do, what you can afford to do. Okay? Good question. Fair question. Ooh, look at that big herniation right there. Oh, yeah. One of my viewers, or I think it's just a hater to be honest with you, was commenting that some of my sounds sounded too promiscuous. So I have to refrain from being too excited while I'm operating. I don't want to offend anybody. At least not people that I like. Right? I'll offend people I don't like. So I'm trying to grab that little piece out. It's not wanting, let go please. It's not wanting to come out. These are very delicate. Hey Carl, does Luis know where to go to buy more of these grabbers? And should we need it? Because those are like over $1,000 a piece, at least last time they were. And if that gets damaged, I need more. So please make sure before you go on your Sinbad's voyage around the world. Laser on. And by the way, I really think you should watch the old Sinbad movies, Carl, before you go on your boat trip. There are some things you may want to look out for. How many people know what I'm talking about? Bharat, do you? You don't know? Did you ever watch the old Sinbad movies? I think it's like Sinbad. How about you?
I haven't watched the movies, all I have watched
No?
the shows at Disney.
Disney. Oh, Sinbad, my God, I guess I'm getting old. That's terrible. They're really, really, really old movies about a ship and the adventures of Sinbad sailing around the world and what he encountered and all the bad things he had to fight off. Huh?
On TV.
Did you watch it?
On TV.
No, did you watch Sinbad? Maybe that's why you have this wanderlust, Carl. This midlife wanderlust. You want to go and do the... Oh, look at that herniation that just came out of the foramen. Beautiful. Beautiful, beautiful, beautiful. Right on the nerve root, that was. Deliver it. Goodbye. Have a nice day. Please come again. Not. All right. So we're just about done. I need 10 minutes. We'll be ready to be extubated. There's another herniation. Everybody wants to leave the party now, huh? Now that Dad's here with a big stick. Luis, I'm glad somebody appreciates my sense of humor. Right? Listen, if you can't make humor, then things get pretty boring and dull. So that's the foramen. There's not much left in there now. And this is just scar tissue from all the inflammation. That's the uncinate joint right there, by the way. Pretty damn cool. Bet you've never seen that before. And that's where that herniation was, right there. You see a tear? So it's all gone. Goodbye. I'm done. We're just gilding the lily now. So let's go look at the other side real quick and make sure there's not more tear over there that I need to address. Looking pretty good. Pretty intact posterior ligament. The white stuff. Really not much over here. Just a little bit, tiny bit, nothing. There's a little tear right there. This is the most amazing surgery in the world, folks. Really is. It's just every time I do it, I fall in love with it again and again because it's so minimally invasive and so perfect. You know, if you understand what an anterior cervical discectomy is, if you understand what an artificial disc surgery is, you're literally removing the entire disc just to get a little piece in the back out. And then you're stuck putting in a piece of metal that's going to be there the rest of the patient's life. And all you need to do is go in with a scope. I mean, this is all being done in shoulders and knees all the time, by the way. This is arthroscopic surgery. Orthopedic surgeons do this on knees and hips and shoulders all the time. They say it doesn't work, but of course it works. They wouldn't do it if it didn't work. Point is, nobody's really done it on the spine except for Parvis Cambin, who started back in Pittsburgh. And now, then it went to Korea, and they did a lot of stuff there. Laser, please. I think we're done. Just get this. And then I developed it for the cervical and lumbar to modify the techniques to make it better, with better outcomes, safer for patients so they don't have complications. We've had 0. And make it more effective and less invasive and faster recovery, faster return to work, etc. And that's what I've been able to do. So, yeah, this is it. This is really, in my opinion, the best way to treat herniated discs in the world, by far. We're done. So Zach, I'm gonna come out with the laser and the tube, and I'm gonna show you this incision. I'm just cleaning up the last bit of annular tear right by the foramen. And I'm gonna show you, folks, the entire surgery was basically done through the smallest incision you can ever imagine. All right. I need to, before you give me this, I always need to clean out the water. Okay, Luis? That's this. Ça va? Ça va? You say ça va bien. All right. Neck is supple. I'm feeling it with my fingers right now. Can you see this? No hematoma. It's beautiful. I don't use a blue towel when I compress the neck. I use a little Raytech, it's called. So we're done. I'm coming out right now. I'm out. The whole surgery was done through that little tube. Let's protect the laser fiber. Pull it in. Okay, gently. Yeah, take it out. So, Luis, you want to grab this fluid adapter? What's our next surgery? It's a lumbar laser? How many levels is the next one? Huh? One's bilateral. Okay. So yeah, I think you're right. I think our next patient's from North Carolina or something, right? Jacksonville. Okay. Not so far away. So I'm applying pressure. We need to do this for a few minutes. Why? Because venous bleeding will always stop when you apply pressure. And if there's any veins that are bleeding, I want to apply pressure. Are there veins bleeding? I have no idea. There's no way for me to tell. Even if I took my fingers off and looked at the incision, there's still no way to tell. So this is one of the measures that I take that I've learned over the years. That most other surgeons don't even do this. They don't even pay attention. But by applying pressure for 3 minutes to the incision, you stop venous bleeding in a normal coagulating patient, right? And if you stop venous bleeding, then you probably save the patient from a complication. So the only other thing I'm doing here is I'm massaging the carotid, which I'm not intending to do, but the carotid is right there. So my anesthesiologist should know that. But I'm also applying pressure on the incision and the veins below. So if you think about it, one of the problems with normal surgery is that when you make a cut in the skin and you start dissecting through the tissues under the skin, we call that dissection the surgical corridor. The surgical corridor. It's like a hallway, but a corridor. So if you have bleeding on the surfaces of the surgical corridor from veins, you have the ability of those veins to bleed and bleed and bleed and bleed and bleed because there's a big space. The surgical corridor creates a big space. We call it a potential space. It's not really a space because the tissue edges are touching each other when you're done with surgery and you close the wound, but it could be a space, therefore it's a potential space that has the potential to be a big space. How is it going to become a space? Well, if there's bleeding after the surgery into the wound, then the blood clot will spread the tissue plane apart and it'll create a big space. So that's why it's called a potential space. So this surgery that you just watched avoids big potential spaces. Therefore, it reduces the risk automatically just in the nature of the approach to the spine of being a small corridor. It reduces the risk of a large potential space for a hematoma or blood clot. So it's part of the reason why we've never had a blood clot complication is that there is no potential space. It's tiny. as opposed to normal surgery like ACDF or artificial disc, where you have a large potential space. All right, so I've applied pressure for about 3 minutes now. We're going to take a look at the incision. Are you ready, Zach? Now, before you look at the incision, folks, I want you to think for a minute. The incision that surgeons put to do an ACDF of 2 levels, 2 discs, like we did today, versus or an artificial disc, is going to be about 10 times bigger than this, okay? This is 4 millimeters. So typical incision is going to be about 40 millimeters. Look at this thing. Can you see it?
Yes, sir.
Right here. Tiny, 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 tiny. And the neck is supple. There's no blood clot. Everything is moving beautifully. We're ready to close this incision. Thank you, everybody. Great work today. So for the audience, I'm going to come over to the mission control, and we're going to answer questions and have a discussion, as I always do, about life. And then we have another surgery, and probably will be ready for you in 45 minutes for the next surgery. So the next surgery will be a lumbar, fixing somebody's lower back, Deuk laser disc repair. They've got herniated discs that are causing back and leg symptoms, and they didn't want to have a microdiscectomy. I did. They didn't want to have a microdiscectomy because they didn't want bone taken out of their spine like all microdiscectomies do. No complications. And our EBL, I'm going to say, was 3 mils. And this is a DLDR, cervical. It was a left approach. Yeah, we don't do the patient awake discogram. Left approach, yes, it's fine. C4-5 and 5-6. You agree? Everything else is good. Post-op diagnosis would be the same. Yeah. We didn't find like a tumor or infection or anything. Carl, what do I do with these gloves? Sink? Or where? Huh? All right. All right, I'll be right over there. Okay, Zach? Pretty cool, huh? Okay, Dr. Digmajan here. I just saw our next patient and checked on him. And our last patient that we just did, the first one, is being extubated and transferred out of the operating room to recovery, where she'll spend about an hour recovering and then go home. So our first question.
How long will recovery time be on a two-level fusion, C3 to C5, to the point where you could comfortably vacation?
Okay, so how long would the recovery be for an anterior cervical discectomy infusion, C3-4, C4-5, to the point where they would be comfortable and go on a vacation? So it depends on who does your surgery. And I say that with, quite literally, it really does depend. I would say, average for surgeons doing that, you're looking at about probably 4 weeks recovery. The way I do the ACDFs, I do it differently. My patients go home an hour after surgery, and they literally go home, and then they could be driving, usually within about a week or two maximum. So as far as if I did your ACDF, I would expect you to be comfortable and be able to enjoy your vacation. Obviously, you'd have some restrictions. I would want to know if you're a smoker, if you use nicotine products, because that's going to slow down your recovery. So let's assume for a moment you're a non-smoker having a 2-level ACDF by me at the Surgery Center of Viera. You're looking at 2 weeks before you could comfortably go on vacation. That's 2 weeks is what I would expect. If you're having a bit of a hard time recovering, then maybe 3 weeks.
This one is having a 3-level L5S1 spinal fusion. Doctor wants to do anterior on Tuesday and then posterior to add rods on Thursday. What is your opinion on this? The first surgery is 2 hours, second is 5.
Yeah, so we have a viewer who has posted a very concerning message as far as I'm concerned. They're scheduled for an L3-4, L4-5, L5S1 fusion, and the surgeon wants to go through their belly for the first surgery and then flip the patient over and go through the back 2 days later. So keeping the patient in the hospital for 2 days and then flip the patient over and do the screws and rods on a second procedure. What's my opinion on this? I would say that it's really a bad idea, to be quite honest with you. There was a time in medicine and surgery of the spine where going through the front was the only option, and it was the best option. And that was about 20 years ago. And since then, it wasn't me who developed the surgery, but some brilliant surgeon somewhere, somebody, an engineer, someone figured out, go through the back, and you can actually do exactly what going through the front does and going through the back does in one surgery with one incision and one recovery. And I'm going to tell you something, going through the front, anterior for lumbar, is the most risky surgery you can do. Okay? Whether you do transabdominal or you do retroperitoneal approach, the anterior approach to the lumbar spine is a horrible idea. The complications are horrendous. You could lose your leg. You get an injury to a vein, a large vein like an iliac vein, you're going to lose your leg. I mean, the complications, just go out and Google it. It's crazy. But more importantly, it's been studied in a controlled fashion by comparing different types of surgery, and the transforaminal lumbar interbody fusion, aka TLIF, which is all done through an incision in your back, is by far safer. And this has been borne out through not just me, but by other surgeons and doctors that study these things. So my advice to anybody that's considering going through the front of your belly to get to your lumbar spine, don't do it. It's an old technique. It's still being done by orthopedic surgeons primarily. There are some neurosurgeons that do it as well. And it's literally an old technique, and it is absolutely should not be done. I would never do it on one of my patients. I know how to do it. I was trained to do it, but it's a technique that we stopped doing because it's so risky. Not just in our hands it's risky in everyone's hands. So my advice is don't do it. get either a Deuk laser disc repair done, which is the best, what you just saw, and what we're about to see actually in the next surgery is a Deuk laser disc repair, lumbar. If you can't do that procedure for some reason, then I would do a TLIF, a transforaminal lumbar interbody fusion. Much, much, much safer. But I would not have the surgeon you're going to do your belly procedure with do that. I would go to an expert in TLIF surgery. So somebody who has very low complication rate and a very high success rate. I will tell you that in my patients needing your type of surgery, 3 levels, 3, 4, 4, 5, 5, 1, we do them outpatient, through the back. No belly, but through the back. And you literally go home 2 hours after your surgery. Our patients leave the surgery center at Deuk Spine Institute with a pain level of 2 when they have that surgery done through the back only. And that's what I'm recommending for you. You can have a pain level of 2 and literally be walking around the same day. If you're not sure what I'm talking about, here's what you should do. Anyone listening, I'm going to have Zach post a link right now. It's on Surgery Center of Viera, and it's called Dancing Fusion Patients. I want you to go to this link and watch some of these videos. Every single video on this page is a real patient who just finished a lumbar fusion surgery or a cervical fusion surgery at the surgery center where we do our surgeries at Deuk Spine Institute. And every one of them, it shows you how long from the time we push them out of the operating room when they were totally zonked out to when you're watching the video of them dancing, okay, dancing before they go home. Every single one of these patients, we call them dancing fusion patients because they're literally dancing 2 to 3 hours after their surgery as they're leaving the facility to go home and sleep in their own house in their own bed, okay? You're going to be in that hospital for at least a week, and the amount of blood loss you're going to have is staggering. And the complication rate with that surgery is going to be about 15% in good hands and as high as 50% in bad hands. What I mean is the surgeon and the team do a good job or don't do a good job. Why would you want to subject yourself to that risk? It's crazy. Do yourself a favor. Educate yourself. Learn about a posterior incision surgery. Learn about the Deuk laser disc repair. If you need this done as a fusion, I'll be happy to do it for you. And if money is an issue, I won't even charge you my surgeon's fee, okay? I'll just do it au gratis. So if you're interested, come in and see me or send your MRI in for a free review. But if I were you, I would cancel that surgery. I would cancel that surgery. For anybody in general that's wondering, should I do this? Find out from your surgeon. Ask them. Have them write it down for you. What is the chance, what is the success of getting rid of my pain? Have them put a percentage. Make them commit. Put it in writing. What is the percent of pain relief? And what is the chance of me getting a complication in your hands? In your hands. Have them put those numbers down on paper. At Deuk Spine Institute, the chance of how much pain relief you're going to get after surgery, even with a fusion, is 90%. That's my average. My average at Deuk Spine Institute. At Deuk Spine Institute, our average pain relief for our patients is 90%. Okay? That's not for the laser surgery, that's for fusions. Laser surgery is higher. It's 92.5. Our complication rate for spinal fusions in the last couple of years has been 0. We've had 0 infections, 0 complications. So our published complication rate that we published in a journal a couple of years ago, and it's in PubMed. If you look up Dr. Ara Dugmajian, you'll find it. It's something about transforaminal lumbar interbody fusion with degenerative disc disease. So that surgery there, our complication rate was like 2%, okay? And that's published. That's peer-reviewed and published. Doesn't get any better than that. That's real data. That's lower than any other surgeon you're ever going to find in the United States or anywhere in the world for that matter. So what I'm trying to say to you is if you care about yourself and you care about your loved ones and you want to be there, reduce your risk of complications. Reduce it as low as you can. Spine surgery has complication rates all over the board. Depends on where you go. If you go to a great surgeon in a great hospital, a great facility, then your complication rate will be lower. somewhere around 5 to 10%. If you go to a lousy doctor or a lousy facility, your complication rate will be 30 to 50% of having a serious complication from spine surgery. If you come to Deuk Spine Institute, the complication rate is 2%, 1 to 2%, okay? So do yourself a favor, avoid complications. They're life-altering. You're devastating. And I see people who come here from other places all the time. They want me to fix all the complications, and I can't. You know, I can't help it if the surgeon that came before they did their surgery damaged the nerve. I can't help a patient who can't swallow anymore because the ACDF wasn't done right. There's so many people with complications out there from other surgeons. It just breaks my heart to see them. So my advice to you is go get it done right the first time. And sir or ma'am, whoever's asking this question, the 3-level fusion, going through the front, spending a few days in the hospital in the ICU or wherever, and then flipping over and going through the back, don't do it. It's a bad idea. There's better options, much better options. All right, what other questions do we have, Zach?
Princessing, would it be safe to remove a metal plate that was from a C5, C6, C7 anterior fusion that was done 11 years ago?
So we have a person asking me, is it safe to remove a metal plate from my neck, from my spine, that was from a C5, 6, C6, 7 fusion 11 years ago? The answer is yes, it should be safe. But I need to talk to you and look at your incision. I need to see how the incision was made. I need to know about complications from that surgery. Did you have any? So I'm going to give you an example. I'm going to give you an example of a situation where it's not safe, okay? And I don't know if this happened to you or not, but if it did, it would not be safe. So the surgeon's doing your surgery and they accidentally cut your carotid artery. And during the surgery, they have to stop your fusion and they have to sew up and repair your carotid artery with some mesh. Okay, so now you're asking me 11 years later if I go back in there, is it safe? Well, of course it's definitely not safe because right next to your metal plate, or literally lying on top of it, is that carotid artery that was injured that has a graft or a mesh around it, repairing it, and quite literally when I get in there, if I start moving it to the side to get down to your plate, it will rip open and you'll die. So that's not safe, okay? So I guess I need to know before I can answer your question, were there any complications from your first surgery 11 years ago, or did it go really, really smooth? If your surgery went perfect and you just want me to take a plate out, it is safe. I could do it, not a problem. Now, the other part of your question is, would it be safe to remove a metal plate from 11 years ago? It also depends on who's removing it, like what surgeon. I can think of at least 3 surgeons just in this county that it would be extremely unsafe and that you would be at massive risk of having a severe complication or even dying if you went to them and had them take your plate out. To me, it would be very simple to do, but to other surgeons, it's not so simple. So I don't know if that answers your question properly, but to answer it, yes, I could take it out very easily. It's probably going to be outpatient as long as you don't have any monsters lurking inside your neck. Thank you. What's next?
Do your patients require any rehabilitation after surgery?
Hold on a second. All right, so the question is, do any of my patients have to go to therapy afterwards or rehabilitation? The answer is 100% of the patients do. Every single patient that I do surgery on needs to go to therapy. And they need to get that therapy done for probably 4 to 6 weeks after surgery. The therapy is important because the surgery that I do doesn't fix, hold on a second, doesn't fix everything. It doesn't fix the muscles, okay? That's probably the most important thing it doesn't fix. It doesn't fix muscles. So therapy fixes muscles. And when you have an injury to your spine and you've had it for any period of time over 6 months, you're going to have changes to your gait, which is the way you walk, and changes to your station, which is the way you stand, and just postural changes as a result of that injury. And the reason people have postural changes is because when you injure a disc or a facet or some joint, these things are on both sides of your body. There's a right and a left, right? So with the disc, for example, if you have an injury to a disc, it can be on the back right or the back left, okay? If it's in the back right, then it's going to cause pain whenever you lean to that side, to the right side. So people are going to naturally, to avoid pain, are going to lean to the left side. Well, if you're leaning to the left side, now you're not using the muscles on the left side as much, and the right side muscles are always going to be tight in the back of the spine. So you get this asymmetry to your muscles and joints. And if you let the injury go for too long, you'll develop contractures and inflammation and contractures and scarring inside the muscles and joints around the area of your surgery. So rehabilitation is 100% necessary. Also, even if you didn't have these issues in your muscles and joints, once you get surgery done, you're going to be put in a back brace or a neck collar. Your muscles and joints are naturally going to start to get deconditioned. And we don't want that, because we want your muscles really being in tip-top shape for when you're recovering, so that it holds your spinal alignment in proper alignment. And so we don't want patients to have surgery and then favor one side or the other after surgery. So the rehabilitation is actually a supervised therapy and rehabilitation, where the therapist is monitoring your position and your gait and station to make sure that you're walking right, you're standing right, you're not going to create new problems for yourself. So yeah, rehabilitation is 100% necessary after spine surgery. I don't care who does it, the spine surgery, there needs to be rehabilitation done for the patient afterwards, and it needs to be done properly. We're very particular about who we use for our patients. Next question. That was our last question, and I appreciate everyone being here, watching and learning. I'm happy to teach as long as you want to learn. And if you miss the surgery, just hit rewind, and you can watch it again on Facebook. This was a special surgery because it's an anterior cervical endoscopic surgery. There's only one surgeon in the United States that does these surgeries, anterior cervical transdiscal endoscopic, and that's me, Dr. Deuk in the year 2019. In the future, I think this will be the surgery that everyone does, but unfortunately, adoption of new surgical techniques and spread of technology takes time. And this has been the case since, men and women began walking on two legs. One of the things that we've done as humans, as we've evolved over the millennia, is to share information and ideas and to improve technology and quality of life. And a long time ago, for information to be shared, it had to be passed from one generation to another in the form of storytelling and teaching by showing and demonstrating. And then, of course, we developed paper and now digital media, et cetera, et cetera. But one thing that hasn't changed in thousands of years of evolution are people's stubbornness and willingness to adopt new technology and ideas that work. It's okay to be skeptical. I don't think that's a bad thing. I'm a skeptic. But to be so skeptical you're left behind when the technology changes and improves is really detrimental. And if you're a physician, a doctor, you truly have a responsibility to your patients to keep up to date and to provide your patients with the absolute best care possible. That's what I believe every doctor has a responsibility to do. That's part of the Hippocratic Oath, in my opinion. Unfortunately, what I see in reality is that most doctors don't care about keeping up to date. Most surgeons think they know everything, and they're not willing to learn anything new. And that is extremely damaging, and that's one of the main reasons I'm talking to you today, is I want the public, the people who suffer from their surgeons' arrogance or ignorance, I want those people to hear this message. I want them to understand, I want you, people suffering, to understand you don't have to settle for a physician that is unwilling to learn and progress and move forward and give you the most advanced care in the world that you deserve. You need to go out and find it. And I'm talking to you all about spine surgery and spine care, but you could say the same thing for diabetes care, cancer care, pediatric care. It's all the same, you know, and that there is advances constantly happening in medicine. And if you're relying and waiting for your insurance company to roll it out for you and put a red carpet and show you, hey, here's the best treatment now, forget it. Your insurance company doesn't want to pay for anything. So they're going to actually, unfortunately, keep you exposed and front and center with the old technology so that you're scared away and don't do it. That saves them money. It puts more money in their trust account. So what you need to be focused on is getting the absolute safest and best and most effective care you can get. And that's what this broadcast is about. It's to teach the world that there's a better way to do spine surgery. If you watch the surgery that I'm talking about just an hour ago, if you rewind and watch the Deuk laser disc repair, anterior cervical endoscopic surgery, you are literally watching the best disc herniation surgery in the world. Unfortunately, most surgeons don't even know about it because they live with their heads so far up, you know what, they don't really look and see that there's better things happening around them. And I've got to be honest with you, surgeons are humans. And surgeons don't want to accept the fact that they don't know something significant. So they'll literally lie to themselves and lie to you that, you know, oh, I don't know anything about that. That can't be good. Well, no, it is good. And if you just watch the surgery and watch the patients and see how they do, you'll see there's a better way to do it. Am I hard on people? Yeah, I'm hard on people. They deserve for me to be hard on them. Trust me, don't feel sorry for surgeons that don't keep up to date with the latest and best. They deserve to be hard on them, okay? Because after all, people's lives, people's health depend on those doctors keeping up with the latest advances in technology. So people ask me, Dr. Deuk Major, aren't you a neurosurgeon? Yeah. Well, do you do brain surgery? And I tell them, yeah, I can still do some basic brain surgery stuff. I can do complex brain surgery. I'm actually a very good surgeon for the brain. However, I don't. Why? Because I don't keep up to date on the latest aneurysm treatment techniques. I don't pretend to know everything. I realize I have my limits, and I'm comfortable with that. I'm secure with that because I don't have to know everything. No human being knows everything. I don't care how smart they look on television or the movies. They don't. Because I'm actually one of the smartest ones, and I realize I don't know everything, so even the smartest ones don't know everything. So it's okay not to know everything in your field of neurosurgery. But it's, if you're going to specialize in neurosurgery, whether you do aneurysm surgery or AVM surgery or pediatric neurosurgery or spine surgery, it doesn't matter. Just be the best that you can be for your patients and learn everything you can about the newer techniques, technology that's available. All right? And so don't bury your head in the sand. Don't pretend that you know everything now. You don't. Go out and learn more. I went to literally the top neurosurgery training program in the United States of America in neurosurgery back in 1997, all right, at University of Florida in Gainesville with Dr. Albert Roten, Art Day, Bill Friedman, Rick Fessler. I mean, I could keep going. Parker Mickle, top neurosurgeons in their fields were faculty. They trained me, okay? So I went to one of the top training programs in the world in neurosurgery. So you'd think I'd come out and know everything, which I was very astute and paid attention for 7 years. The truth is, when I got out, I didn't know there was such a thing as endoscopic spine surgery. Really. It really wasn't taught for degenerative conditions in my residency. Sad, but true. So I went out and learned it from a group of surgeons in different locations, one of them being in Phoenix with Dr. Anthony Young, who's like the Yoda of the field. He's a master. So I went and learned it from him because it wasn't available in my residency. Now think about that. If I went to the top neurosurgery residency in the country, so we just say one of the top three, but the top, and I focused on spine, and I was trained by literally at least two of the best top 10 spine surgeons in the country, and they don't even know how to do the surgery, you can see the problem. The problem is a lack of training, a lack of education by the surgeons around the country. If I went to the best and I didn't know about it because my faculty didn't know about it, how to do endoscopic spine surgery, how can you expect the other 2,000 neurosurgeons that go to inferior programs to know about it? And the answer is they can't unless they go out and learn on their own. So the truth is, I'm speaking to the public now, and I'm also speaking to neurosurgeons and orthopedic spine surgeons and anyone that's interested in understanding why things are the way they are. The reason we don't see more endoscopic spine surgery in the United States is multifold. Number one, the doctors that perform these surgeries don't know that they don't know because they literally don't know they don't know. And when you don't know you have a problem, how can you fix a problem you don't know you have? We call it egosyntonic, meaning that the ego is unaware that there's a problem. The ego being, the person's individual ego. So we have an issue of surgeons not knowing they don't know the best treatment. We then have an issue of money because it costs a lot of money to buy this equipment and set up an operating room to do endoscopic spine surgery. You're talking about millions of dollars, which I spent out of my own pocket to do this. And then you're talking about training, and the training to do these surgeries is long. It's going to take time. And honestly, it needs to be, in my opinion, incorporated into residency programs, which are 7 years. But there is nobody in a residency program now as a faculty in spine surgery that is teaching residents this surgery. Really, I'm one of the only ones in the country that know how to do it. And I'm not teaching residents because nobody really wants to come to Melbourne, Florida. They all want to go to New York or Los Angeles. So we have a residency, we have a fellowship, a post-residency fellowship, and it's open to an orthopedic surgeon or a neurosurgeon who I feel is capable of learning these techniques and wants to learn and is passionate about being the best. And if you know somebody who wants to learn, just pass their information on to Deuk Spine Institute and I'll talk to them. But I'm kind of gone off and digressed on a topic that's important, but not really something anybody asked a question about. But if the public is wondering why aren't these surgeries done in my city, in my hometown, why doesn't my neurosurgeon know how to do this? Why doesn't my orthopedic spine surgeon know how to do this? The answer is simple. I just gave you the answer. Number one, they don't know about the procedure and the technology. It's too advanced. They weren't trained. Number two, it's very expensive to start it up. Number three, the training is long. It's going to be at least a year. And there's another factor I haven't mentioned. And that last factor, I'm sure some of you are aware of, is that the alternative to the Deuk laser disc repair endoscopic spine surgery is spinal fusion, all right, or spinal artificial disc. Well, here's the problem. The big companies like Medtronic, DePuy, used to be Synthes as well, that manufacture NuVasive, for example, Alphatech, they manufacture and supply the screws and rods and metal plates, okay? And they make a lot of money, like literally billions and billions of dollars when doctors, surgeons put these metal pieces into patients, right? So what's going to happen with the Deuk laser disc repair is the Deuk laser disc repair is a surgery that doesn't use any metal. We don't leave any implants in the patient. We don't put screws, rods, metal plates, or cages inside our patients because they don't need it. See, when you fix somebody's disc endoscopically, you repair the annulus, you remove the herniation, you don't need to put metal in the spine. You don't need to put plastic in the spine. You don't need to put anything. So that hurts their business because they're in the business of surgeons putting metal in patients, and these companies make a lot of money for that. They actually make literally billions of dollars a year. So they are against technologies that are new, like the Deuk laser disc repair, that fixes people's disc herniations without metal or plastic being put in. And you might start feeling angry about this, hearing this from me, but it's the truth. And the truth is you really should be angry because they're controlling these surgeons. They basically brainwash the surgeons. And here's how they do it. They literally offer these surgeons money to use their products. And it's basically disguised to the public as a stipend, okay, in the form of, hey, come and give a lecture and we'll pay you $3,000 to some other surgeons. So come and give a lecture to some other surgeons and we'll pay you $3,000. Or create some nonsense technology and we'll pay you hundreds of thousands in royalties for it. Anyway, I could go on about this. I know about it. I personally take no money. I don't get any royalties. I don't do any stipends. I have not. And I have nothing to disclose. I have no outside influences. I do fusions as well. I put in screws and rods. At times I put in $2 million a year worth of screws and rods and plates, all right, doing fusions as a surgeon. Is $2 million in implants a year a lot? It is. It just goes to show that I'm a busy surgeon, nothing else. Do I take any money or cash or anything at all in exchange? 100% no, I don't. Because do I think it's wrong? I don't actually feel it's wrong at all. But is it illegal? Yes. And because it's illegal, I don't do it. I don't break the law. So I get it. I don't do it. But just about every other spine surgeon out there does. So you're wondering why there's so much fusion going on rather than natural ways of fixing herniated discs like the Deuk laser disc repair. The answer, in part, is due to those three other factors, but the fourth factor, which is very big and very important, is the influence of the implant companies like Medtronic, Alphatec, NuVasive, DePuy, that make the implants, the screws, rods, and plates and cages that go into patients' spines. They don't want to change the balance of the equation. They want to continue to profit off of implants going into people, even though there's a better technology, the endoscopic disc repair, out there at Duke Spine Institute. They don't want that technology available to patients en masse. So how could they possibly count? Well, number one, they influence surgeons. And surgeons talk to you, the patient, about your options for treatment, right? And so they influence surgeons to make surgeons want to put in implants. The surgeons that influence you, the public, which I think is wrong. I think that you should always give patients all the options that are reasonable. And that's what I do. That's why there's so many of these laser surgeries we're doing, is because I talk to people about both options and I let people choose what works for them. I don't influence them one way or the other. In the end, for me, a fusion versus a Deuk laser disc repair, they have the same success rate. It's just a fusion takes longer to heal from, is more risk. So if the patients want to, do the laser, it's less risky, it's a faster recovery, it's less pain and trauma. I think that's a great option. If they don't and they want to do something else, they want to do a fusion, that's fine. So I need you, the public, to know the truth. I think the truth is important for people to know. I think the truth's important for people to know because, honest to God, I cannot imagine a society where everything people say to each other every day is lies. And we will stop making progress completely. I truly believe for us to make progress as a society, we have to be honest with each other and honest with ourselves. So this is my own personal philosophy, right? And we're not going to make progress unless we're honest. So I think we need honesty injected into this specialty of spine surgery. We need honesty. We need the public to know the truth. And really, the other thing I think is that if you're honest with people, they're going to make the right choice. The right choice is the choice that's best for the patient, best for themselves. And to me, that's my job as a doctor, is giving my patients the knowledge so that they can make the right choice for themselves. Now, to do that, I have to give my patients all the knowledge. I have to give them insurance information, what will it cover, what will it not cover. I have to give them outcome information, what surgery gives you a higher success rate of getting rid of pain in the back, in the leg, in the neck, in the arm. I have to give them information, honest information about complication, what's the chance of getting a complication? Is it 30, 50, 100%? Is it 1%? So when people are empowered with knowledge and facts, they can make the right choices. And I'm dealing with this exact same issue in the marine biology world, because my hobby and side job is doing marine biology, basically trying to find a way to cure the dying coral diseases out there that are killing all the corals in the ocean and in our tanks at home. And it turns out that it's an infection with a parasite that I discovered as the cause, and I did so through good scientific research and experimentation. And the fact is, I'm trying to educate the public now about the cause of coral tissue necrosis. And just like in medicine, there are those people who want to know the truth, and they can take the truth, no matter how bad it is, and they can work with it and prepare and plan and do what needs to be done for themselves. And then there's a lot of people who can't take the truth. And so I'm talking to you all about spine care, and there are people who can't take the truth. So they're out there. But the more we talk about the truth and the facts, I think the better off everybody will be. Do we have any more questions, Zach?
Nope.
All right, I hope you enjoyed the broadcast. I'm Dr. R. Deuk Majan, CEO and founder of Deuk Spine. And we'll be back in about 20 minutes with the next surgery.